am Ira Kirschenbaum. I am the editor of the Journal for the Orthopedic Experience and Innovation. We have a great session tonight. We are going to talk about, this is our second one doing it, but as Walt Frazier says, if it's so nice, you do it twice. Okay? And that's what we do if you're a New York Knicks fan. We are going to be talking about the No Pain Act. Okay, and with us today we have uh, two and a half guests. The other half's not here yet. That's Joe Abboud. He's coming pretty soon. He has to finish up something else important, probably completing the entire program for Orthopedic Summit. Um, we'll see what's going on. And I'd like to introduce, first of all, Shariff Bishai. Shariff, you're on mute, man. You're mute. You didn't unmute
Did
yet.
I get muted by you guys? Because I didn't
No,
mute myself.
no, I think when
Um,
you came on, you got muted. Yeah.
all right. No, Sharif Bishai from Detroit, Michigan. I'm excited to be here. I've been using the XREL interscaling block since 2018. And now that there's an opportunity for more of us to use it and see opiate use come down, and now that the No Pain Act is out, I'm really excited to be here so that more people can learn about it.
Okay, I also like to introduce Todd Killian. Todd, you want to introduce yourself?
Sure. Good evening, everyone. I'm typically out of Pittsburgh, PA, but today I'm in San Diego. So 5 o'clock here and 8 o'clock out there. So I'm the senior vice president at Pacera. I deal a lot of the reimbursement and market access, but I've been in this industry for, geez, a little over 25 years. Work for companies like Pfizer, Merck, Allergan, but really thrilled to be here at Pacera. Very mission driven. Looking forward to getting into some of the questions Dr. K, that you have, and anyone else that has as well, then more than happy to answer and get in these kind of discussions. So thank you for having me.
Yep. I'd also like to introduce two people who are technically not panelists, but who are longtime Joey content experts. Anand Murthy, I'm going to put you on the spot because you know a lot about this topic. Why don't you introduce yourself, Anand?
Hey,
Oh, I think we just lost you. All right. We're going to move over to Laura Wynn. Laura, you know a lot about the No Pain Act through a lot of work you've done with another company.
Yes.
Why don't you introduce yourself?
Hi, everybody. I'm Laura Wynn. I'm the Chief Academic Officer for Joey. And I also have done a lot of work in the opioid sparing area as it applies to orthopedics. And I'm so excited because I feel like this is an important discussion. The last time we all gathered to discuss the No Pain Act was before it came to fruition. So now I'm hoping to hear about some EOBs and some great experiences. Really excited to be here tonight.
Excellent.
hey,
You're
hey,
back on.
I'm back. I'm back.
All
Um,
right.
Thank you so much. I think this is a great platform. You know, we've done a bunch of Joeys, and there probably isn't anything as important as the pain control and patient outcomes. And I want to hear about your experience too. We talked a little bit before it started, but XPREL is a huge game changer, and hopefully I can talk about some of the frustrations we've had, and we'll go from there too later tonight.
Excellent, excellent. I We have mainly a good full house right now. If you have anything that you'd like to ask a question, put it in a chat. I will call on you, ask you to please show your video just for production purposes, and we will take it from there. Um, I am going to introduce us, everyone who has seen it already. This is my hip. This is 2 weeks and 3 days ago. I had my left hip done by Andrew Wickline, who is a big proponent, No Pain Act, um, early adopter of a lot of the products we're going to be talking about tonight. I think he used every single one of them on me. My personal experience was not only no opioids, no tramadol. I took two 1,000 milligram Tylenols a day for the first week, and that was the only pain medicines I took. Um, and I drove to the mall today and walked around a little bit. Um, and but I didn't buy anything. So that's it. That was the negative part. So I'm going to start off. We're gonna get going, and I'll ask Todd maybe why do you think legislation was needed at all? I mean, because pain's been around a while, and people have been treating pain for a while. So what's the origins of this No Pain Act?
Yeah, so this was a long time coming, Dr. K, for sure. So I think that most of the folks that are listening today, yeah, there is for sure, and still is, an opioid epidemic out there, right? And so this entire act, a bipartisan law, was really designed to reduce opioids. That was the design of this, and people coming together from Congress, people, societies, patient voices as well, physicians as well, to understand the need that we need effective pain management without the risk associated with opioids. And to me, that was really why that this all came together, and obviously was adopted just this year in January. And I know we're going to get into some of these, but another area for this is because there was barriers to non-opioid pain management. And when you have barriers like that, in particular from the payer community, from the Medicare side as well, then you opt to something you continue to prescribe, and typically that is the opioid route. So now, for the first time, we have Exparel and Iovera, by the way, a device also that are separately reimbursed, mandated by CMS on the Medicare population. And we'll get into how we believe we're going to expand this as well to the commercial payers also.
Sharif, what has been, you've been in practice for more than a week, quite a few years, and now you're at the Detroit Orthopedic Institute, which is your own show. Uh, what were the challenges you were having with your painful surgeries that you think contributed to the need for this change, this bipartisan change?
Well, I think that shoulder surgery notoriously, when you talk to patients even now, and Anand and Joe will probably agree to this, they'll say, I've heard that this is the most painful surgery that I can have. And so the realistic aspect of it now with something that's available like Exparel and a multimodal approach and low to no opiate use is that we can make this a realistic endeavor for the patient, that we can be very honest with them and say that we can do this with minimal pain. And oftentimes in an outpatient setting to do a replacement, to do cuff repairs, to do latarjets, to do all these big surgeries, but do it in a manner where we can do it with little to no pain. And I think that when you start seeing that with your patients, you realize the barriers we went through before, whether it was an argument with anesthesia of whether they would do the block or not, because before it was interscaling block, they didn't want to lose the procedure. So I apologize to any anesthesiologists, but the reality was the reality. So we would do a field block of Exparel. And so it was a little bit about cross-contamination between anesthesia and orthopedics. And then it was P&T committees from the hospital saying that it costs money. So there was all these barriers to getting it to the patient. And the reality is none of it had to do with the patient or the surgeon. None of it. And now we have this ability, thanks to the No Pain Act, that we are able to offer this and really kind of change the paradigm of, this opiate discussion and have a real conversation, because more people than not now are coming to me saying, I don't want to take anything. I really want to do this in a capacity where I can do it with little to no pain. Before this, we couldn't have done it.
I also like to introduce that Joe just came on, Joe Abboud. Um,
Hi, Ira. How are you?
Hi. Yeah.
Thanks for having this meeting on this important topic.
Yeah. Everyone knows you, including me, but why don't you just introduce yourself briefly? There may be somebody from Botswana who's doesn't know you're here.
Um, Joe Abboud. I'm an orthopedic surgeon, shoulder elbow specialist at Rothman Orthopedics in Philadelphia. And really enjoyed being on Joey and the topics they bring to the public. So thank you.
Excellent. Thanks, Joe. Um, so let's talk a little bit about the statistics and trends that were happening in opioid use. Okay, and what was going on before we started. How many opioids were surgeons using? Were we thinking about this about 8 or 9 years ago, Joe? Was this even on our radar? Or early. You are early in your career, but earlier in your career.
Yeah, no, I mean, I think that, when I was training in the late 90s, early 2000s, it was pretty standard to prescribe 90 pills of oxycodone or what have you to a patient, Percocets, once or twice or three times after surgery. And so, I think it, with pain being the fifth vital sign back then, it was considered inhumane to have people experience pain or suffer. And honestly, it was a difficult conversation. I think a lot of providers here would agree to tell somebody, we are not going to prescribe you any more narcotics. It became at times confrontational, threatening.
Yeah.
There's been physicians that have been unfortunately murdered over this. So it's hard as a physician to have a patient in a room who sometimes can turn hostile because they're addicted and they're not in the right frame of mind, to tell them they're not going to prescribe it. They're going through withdrawal, et cetera. So, 10 years ago, I can recall one of my research fellows asking if we wanted to do a educational tutorial on the dangers of opioid prescriptions prior to surgery, and doing a randomized study on it, which ended up winning the NEAR Award. And ASCS was a study we did with Luke Austin, my partner, and others at Rothman. And at the time, I don't think I fully understood the value of that study. It was a young student who was interested in the topic. But, as time has gone on and the government has acted in the right way and implemented some of these changes, it's provided us a backbone to say, no, we can't prescribe this. It's provided surveillance, much needed surveillance, and provided us an ability to say, look, I can't prescribe any more of this. And so I've seen a drastic drop off in the number of narcotics or opioids patients are taking. And like Shariff was saying, there's a tremendous awareness of the potential addiction to opioids, whether it be somebody younger or somebody later in life. They really do not want to be exposed to opioids, or if they've had a previous problem with them, they understand how dangerous it is, and they want to try to do their surgery without any opioids at all.
Interesting. And if you want to comment a little bit on what barriers did you find about 5 years ago when you wanted to bring in products or devices related to pain in the hospital?
Yeah, initially, we had heard about Exparel, and just regional anesthesia in general was relatively novel. I mean, I think 5 to 10 years ago, and then that worked okay. And then this advent of Exparel or liposomal bupivacaine was just a big game changer, but still is technically dependent on your anesthesiologist or your team. It was a cost issue. I think bottom line, when you work at a big hospital system like MedStar, they look at line item costs instead of kind of an overall, what's the patient outcome cost, customer satisfaction, those kind of things. So I think now with the decrease in bottom line cost of Exparel, and I learned from Shariff at the 360 meeting that it's cost neutral or even 6%, right, Shariff?
Yes, sir.
Did I listen correctly? See?
You did, my friend.
That I think that's just something that these systems need to be informed about. I think it just needs to get the word out, because they still, when I talk to my colleagues, the cost is still kind of one of the blocks. I don't know if everyone else agrees to that, but there's kind of still a cost issue.
Yep. Shariff, what do you think about that cost issue now?
Well, I think that, with the No Pain Act, Medicare obviously is covered for these patients, and now Cigna and Aetna have followed suit. And usually once you start seeing a couple of the commercials, then the Blues will follow and so on. So it's going to be a difficult conversation for the Blues to not do it when there's an opportunity for better care, less pain, less possibility for addiction to opiates, less opiate prescriptions being written, and they're going to be the ones that don't have it. It's not a good look. And right now, there's not a great look for insurance carriers. So they need all the help that they can get. And this is one of them, which I think is beneficial for society and for our patients. And I think to allow us to take care of these patients better without significant pain.
So how does Todd, how does the reimbursement actually happen now because of the No Pain Act? Do people just put it in as a line item? Do you know how that actually works? To that
Yeah,
high?
for sure. Yeah, for sure. And
I knew
let's
you did.
comment on.
That's why I asked.
Yeah, no, for sure. No, great question for sure. Because it's something that we talk about to all of our healthcare practitioners. We talk to the facilities, the IDNs as well, and everyone has to come together because that is a true barrier is reimbursement. And if it's just lumped in to the cost of the procedure, that's what is creating one of the barriers. So the reimbursement now with Medicare and the No Pain Act. Every Medicare patient that's in the HOPD setting or ASC setting, when they're coming in, it's carved out, completely separate. And I think that someone said today or just earlier, they now get reimbursed the ASP of the product plus the 6%. So that's where that 6% comes in. And when you have something like that to have an option with Medicare coming in with these patients, and now we're going over and the receptivity to the commercial population. And again, I love hearing that because I have a team dedicated, by the way, calling on these payers to drive value of Exparel, and they're being very receptive to the value of Exparel and trying to align their Medicare Advantage population with no pain and their commercial population. So we did have really big wins with Cigna, Aetna, and we actually just got TRICARE as well. And so I believe more to come. We are engaging with the Blues plans also, but that's how that reimbursement mechanism does work. So it comes in the claim, they submit it, and on the Medicare side, on HOPD and ASC, it's carved out of that bundle, so it's separate reimbursed, the whole buy and bill model. And now we're engaging the commercial population as well to align those policies. And we believe that it's going to take a little time to implement some of the no pain like there. We have to get into these EMR systems, make sure we have a brand new, I should mention, J code as well, J0666. That also really helped to enact, I think, and they're not just the separate reimbursement, but now is a very specific product J code for Exparel, which is also very receptive to the commercial population as well. So that's sort of how that reimbursement mechanism does work. How they have to get reimbursed really is designated by the payer policies. But we have Medicare now, guaranteed separate. It's a mandate. And now we're aligning the commercial policies there as well.
And Ira, I'll jump in real quick. Todd, that was
Yeah.
a great explanation. And I think the only thing that as a physician we need to do is when we dictate, we have to dictate that Expro was used in whatever the 133 or the 266 vial. And anesthesia will also do that, but they need to see it in the op note and in the anesthesia note so that they will reimburse the J0666.
That's
And
right. Yep.
I want to share my screen and just put this up for some people who may not know I want this for production. The No Pain Act actually stands for Non-Opioids Prevent Addiction in the Nation Act. Um, and it requires to provide separate reimbursement, tries to remove financial disincentives, and combat opioid overuse and addiction. I just wanted to get that up there formally for the recording and for everybody to see. It's not just no pain. It actually was really directed at opioids. Larry, you want to make a comment on the reimbursement side at all? Sorry to put you on the spot.
No, not at all. I mean, I think this has been a long time in the making. Pacira was at the front lines fighting for this legislation from the early days. And, finally, it's taken a while, but CMS has, they announced their final rule. And I think this has paved the way for reimbursement and a pathway for reimbursement for opioid alternatives that is so important. I'm excited because the reimbursement is designed so that there is a $0 cost offset. Many of you are familiar with reimbursement in your offices with products like Zolretta or visco supplements, where the reimbursement is average selling price plus 6%. And that is exactly how the reimbursement should work out for Exparel in ASCs and now also HOPDs. So this is really an exciting time, and I can't wait to hear from some of you here uh, who are seeing, EOBs and seeing these payments come through. I'm also hearing rumblings that there are some commercial payers that are already very early jumping on board. So I'm excited to be here for this call today.
Let's talk a little bit about you know, how does a modality get on the No Pain Act? I mean, is it just, do you need a J code? I come up with a new super long-acting Tylenol. I'm making this up, super Tylenol. Does it automatically go on? I mean, do you have to apply for various things? I mean, how does something get on this No Pain Act? Todd, do you know that answer?
Yeah, so I can start for sure. So look, I mean, there's what the good thing for us really it's about non-opioids pain management, right? So that's first and foremost. You have to have those indications in there. I think I mentioned we have Exparel, we also have a device, Iovera. There's pumps on there like OnQ. There's another one, Zenrelef. There is some ocular products on there for ocular inflammation and pain. It's basically a dexamethasone as well. So I believe there's 7 or 9 products and devices on there currently. I don't know if there's going to be any added. I should just make that comment. I'm not sure there's going to be any added products on there. But first and foremost, it has to be a non-opioid pain management modality. And then you work with the congresses and move forward from there. So this isn't a long road. I would anticipate that what we have currently will stay in place unless there is some add-on that I'm not seeing right now. But that's basically how you get on.
Yeah, I would add too that it's really quite simple. I think that the eligibility is based on three things, right? That the drug or device is FDA approved, the fact that there's evidence in clinical trials and peer-reviewed journals, and that the labeling for the product states that the drug is an opioid alternative. And I think it's quite simple. So a number of products, that claim to be opioid sparing did not make the cut because they missed out on one of those three requirements.
Right. Is it public knowledge everywhere what qualifies and what doesn't? Or you just or that's public knowledge.
It is. I believe there are 11 products.
Well,
There are 6 drugs, I think. So
mhm.
it's like, and device, and maybe 4 devices. But Pacira really led the charge with Exparel, and then Iovera is now on the list.
Interesting. Interesting. Joe, in your practice, are there surgeons not taking advantage of all these modalities? Some still holding on to old school opioids. And, one of the reasons I bring that up is there was an article in Journal of Arthroplasty that showed the average arthroplasty surgeon is still writing and I think an average 108 was the article, 108 pills. So, what's going on with all your colleagues? Are they all on board with the same approach you have?
Um, so, we do surveillance centrally in our practice.
Okay.
So we by division look at average prescribing practices, and each division has a little bit difference based on whether it's spine or hand or foot and ankle, shoulder, elbow. But if there's any deviation from kind of the average, the quality committee kind of reviews it with your chief and sees why there's a deviation, and then there's a monitoring for a period of time, and then if there's not a response, there's remediation, et cetera. So we do take it very seriously. I think in this day and age, there are so many options, right? So we've done a study on prospective randomized use of Tylenol perioperatively, 1,000 milligrams Q, 6 to 8 hours, in addition to an anti-inflammatory. And I think for years we underutilized anti-inflammatories because of the concern about either tendon to bone healing or bone healing. And our use of liposomal bupivacaine or blocks perioperatively, and making sure that we counsel the patients on it. I think all those three things, shoulder surgery, as Shariff was saying, is fairly painful surgery.
Yeah.
It's pretty rare that someone goes through more than 10 to 15 pills after a shoulder arthroplasty in my practice. And there are several patients a month that will say they use none or one or two opioid pills. And so, we have to be really careful about the prescription of oxycodone, one of the most abused drugs in the world, as far as exposing patients to that. And we as orthopedic surgeons prescribe more of that than any other providers.
Yeah, I'd like to introduce two other people who are here. Vani Sabizin, also a shoulder surgeon as well as others. So Vani, you want to introduce yourself? Because I know you
Of
have.
course. Thank you for inviting me. This is an awesome thing. And obviously, you have the best lecturers here with Shariff and Joe leading the way. But I definitely think this is the future. And I think you just are so spot on to have this. And I think the fact that we can get money back is the key.
Yeah, absolutely. And Michael Redler, I see you there. Talk to me about what your protocol is these days in shoulder surgery. We'll talk shoulder first.
Mike is the most pain-producing shoulder surgeon in the country.
Yeah. Yeah, he's the opioid
Sharif,
selling
don't lie.
opioid.
Sharif's laughing, but he's laughing in support of my statements.
Especially in Honduras.
Actually, hey, Michael, you should tell them the Exparel Honduras story.
Well, Anand, with an introduction like that, I'm almost speechless, but not quite. Listen, I want to thank everybody who got together for this meeting tonight. This is a topic that now has become more prevalent. We've talked about it more, but frankly, the work is far from done. And so educating people, being aware of the No Pain Act is so important, and it's ironic to see who's on the group tonight, because frankly, the way that I got introduced to opioid sparing, even though I had it in my mind, is Laura Wynn introduced me to Scott Sigmund many years ago at a Pacira event. And now we come full circle to the point whereby we're continuing to have this great validation in terms of what we do. Every patient has to have great education. That's what we talk about in terms of why we want to minimize opioid use, what we're going to do about it. And we talk about that in the office when we see the patient. We talk about it again when we see them preoperatively, and we talk about it postoperatively when we talk to them afterwards, hopefully with a family member. And the bottom line is, by using these long-acting local anesthetics, by having great anesthesiologists, we have come so full circle that minimizing opioid use is just a tremendous advantage now from what we've done. And I think that what we do now is we educate the patient, we use Exparel, we use long-acting blocks, and we've really hit it out of the park in terms of what we've been able to accomplish.
Okay, I want to bring up one other thing. I'm going to share my screen again. A shameless plug for my hip surgeon, Andy Wickline, who is crazy about the concept of swelling. Okay, his book, Less Swelling, Less Pain. And he's using a lot of irrigants, edema wear, and a variety of products. Does anyone want to talk about other modalities to decrease pain? Any techniques to decrease swelling in the knee operations or your shoulder operations? Because that seems to be a cause from there's a transitional pain, as Mike, about you and Scott and Laura have talked about that from the podium for a long time. What do you do from day 3 to day 21 in a lot of this stuff? Someone want to comment on protocols for that?
So Ira,
Yeah, Kevin Blanchard. Oh yes, Kevin, how are you?
I'm great. How are you? Nice to see everyone. You know, my mentor, Dr. Stedman, said I don't want to say when, ice. So ice was not considered the modality with the anti-inflammatories, and he started back in the 90s. He only used anti-inflammatories at that time, and I will tell you, so my protocol is an Exparel. It is anti-inflammatories for anything and everything. I'm not worried about healing whatsoever, never have been. And so that's knee and shoulder, and it's also using cryotherapy. And I think Andy is correct. Swelling is the key. The pump pressure should not be high, which is another reason people have pain post-operatively because they can't see. So you need to get the anesthesia team on board with yourself to lower the blood pressure safely. But I was curious, Ira, in the group, because I'm not embarrassed to inject if it's a revision ACL, in the knee, in the joint. I know I'm a doctor out of label, into the joint, in a rotator cuff. I mean, when you have these wonderful drugs, but I think it's important the how you administer the drug by the label of using a smaller needle, creating a bubble in the soft tissue. So it's also important. And I don't know tonight that we're talking about Zaretta as well. So there's so many things that you can work with the patient that narcotics are just not a conversation. And yes, when it is a young male, less than 45 smoker, yes, these are the risk profiles that we know about narcotics. But I think it's really not as difficult as we think. And so I'm happy to espouse the word. And now, as Vanny says, for those that weren't getting paid, I think it's terrific that we have it. But it's cryotherapy for me that helps, along with some of the other products that this company, Pacira, can offer to decrease pain.
Yep. We have a new message here. So hold on. Marty, you want to make a comment? You make a comment here.
Yeah, more of a comment than a question. I mean, I love this so much and just kind of wanted to point out that first of all, thanks to the doctors in the industry that have pushed this through, and then point out the irony that it was actually the doctors in the very industry that Stark wrote laws to stop from overscripting that have stepped up and got involved and actually stopped the overscripting of a very dangerous drug. I mean, kudos. Thank you to all these people.
So, the question really is what's maybe coming down the line and what would people like to see? Okay, if you had your wish list to talk to the R&D department of Pacera, or to the R&D department of Joey, we don't have an R&D department actually. Um, we have an R&R department, rest and relaxation. But what do you want to see coming down the line? What do you want to, does anyone have any comments on that? What's your wish list now?
My wish list is to be able to do complex surgery, the high acuity cases that everybody on this group does, and use no opioids. And how do we do that? Well, part of that is trying to bridge the efficacy gap. And the efficacy gap is even with the best regional block, you probably have that 72-hour period of time. So, there are a couple of companies now that are looking forward towards how do you get to that next step there as well? Is it going to be neuromodulation? Is it going to be another option as well? But the point is, if you can get something where it's minimal opioid use, there's so many advantages of it, it will blow everybody away. And I want to say one more thing for everybody in this call. If you've not read it and you talk about how the whole opioid crisis that so many people like Kevin have referred to, read the book, The Empire of Pain. It reads like a novel. It talks about how this got built up, how physicians got seduced, how the press got seduced, and how it was the perfect storm. But it's a great background for anybody on this call who's had an interest to sign in tonight.
Great. Any other comments on what we'd like to see down the line on this?
I'll jump in. I don't know what I necessarily want to see, but I want to be able to, as Michael said, do these complex cases and do these cases that these people need without the headache of bureaucracy. So I think that's the key. Is I don't know what the future holds, but I just want to be able to use it. There's nothing worse than having it at arm's length, but I can't use it because somebody tells me it's expensive. So I think something like the No Pain Act and more ways, as even Laura was telling us, how to get more things in it, it's going to be the key. So as more things come up, be able to incorporate those into the No Pain Act because it's going to decrease opiate use.
I
Also
agree
going to
with that.
drive costs down, which creates more competition, which also will be beneficial to consumers.
Agreed.
I agree with what Sharif said. It's the headache, and some of that's with the education, right? We're trying to educate large hospital systems and large medical systems on something that they don't believe in, that a patient can have surgery and have no pain, especially, we all have patients who come in and say, oh, I hear shoulder surgery is the worst. And they look at you funny when you say, oh, no, my patients don't really have pain after surgery, standard primaries and opioid naive patients. So I agree. Somehow we've got to continue to educate and push, and these webinars like Joey and things like that are getting the message out, but we're still a little behind.
It's also, a budgetary issue, kind of in line with what you're saying on, and, for us, it comes out of the pharmacy's budget, right? And so
Right,
they
right,
don't
right.
want this oftentimes under their budget.
Yep.
And it's ironic because anesthesiologists are supposed to be experts in pain control, but oftentimes, like at my hospital, they haven't pushed for it. Chairman hasn't approved it. They've kind of looked at the literature in a slanted fashion, and said, well, we don't see the efficacy of X, Y, and Z. Therefore, we're not going to approve it still.
You hit it 100%, Joe. It's the pharmacy side. Our head of pharmacy for all of MedStars, balking at Exparel based on they sent a article out from 2015, right? That's where they're working from. So that's the frustrating part. But you hit it on the head. It's on the pharmacy side that's tough.
I
Yeah,
will. I
oh,
will
go
say
ahead.
that we've fought that at Beaumont here, or Corwell, whatever the name of it is now. Uh, our friend Michael Wider and myself really fought it all the way through the P&T committee, and we were able to get it passed. And a lot of that was because we were able to reach out to our local representation for Pacira and work with them and get the appropriate materials to pass along to the P&T committee, so they weren't looking at 2015 data, because the data back then maybe wasn't as great as it is now. I mean, we're seeing huge opiate decrease of use with those Exparel patients, and more education. And now I think, like we said earlier, with the increase of knowledge about this, it's tough for a hospital to say we're not going to pay for it now, because they don't want to be the ones that say we're not using it. And at least in Detroit in private practice, I'm quite nomadic. So if they're not going to let me use it, I can take my cases elsewhere. And so they have to start looking at those spreadsheets and saying, well, we might not want to spend whatever $100 or to lose a whole case or to lose a whole full day of cases. So then they have to start thinking about it from a more, you know, cost containment standpoint versus just looking at it as a way to just say no because it's coming out of a different spreadsheet. So
Well, I
thanks,
gotta tell
Pacira.
Yeah, well, I got to I have to comment on that. So if I could, I think I'd take this whole panel, all of you guys around with us, to all the IDNs, all the pharmacy directors, and all the payers as well, because this is resonating deeply to us. And the reason why, I'm glad someone brought up the pharmacy. That's one of our biggest barriers. So I know we talked about the payers and the reimbursement there, but on the IDN side, that becomes a barrier. They look at budget, they look at bottom line. But because of the No Pain Act, and I think Lara, I think you were mentioning it, we are now looking at these EOBs. We're looking at revenue cycle reports as well, and they're starting to see the separate reimbursement on there, on the Medicare side and on the commercial side as well. We then can take that information and go to these pharmacy directors, go to these IDNs, and go to the facilities, and basically it changes practice economics. And that's really what it comes down to, a lot in particular for the pharmacy director. So now we're arming ourselves with more, not just the value of Exparel, but now the economics has changed because of the No Pain Act. And we believe that's starting to resonate. So more voices like I'm hearing from all of you can help, drive this value as well for non-opioid alternatives like Exparel into the institutions, because that pharmacy, that P&T committee does look at dollar signs. And now with the difference in the economics, I believe that it's starting to resonate to them, and we're starting to see more and more uptake as well.
Todd, may I ask a
Yeah.
question? I mean, how do you feel the penetration is in the marketplace of surgeons understanding No Pain Act and the fact that these products are reimbursed in both ASC and HOPD settings? I mean, is it 5% of surgeons realize this? Is it 30? I mean, where are we and where are we going?
Yeah, you know what? I don't know if Jen Berman's on. I know she keeps track of that as long. She can definitely comment on this, but I can tell you from being out in the field, we are starting to see more receptivity. And Lara, to your point, you're talking about ASP and no pain. It is new, so there's education on it, and how do you prepare for it? The J code, for instance, how do we crosswalk that? We had a C code, now to the J code. So there's definitely education, but once they start to understand what you just started talking about, it's like, hey. Okay, here's a no pain act, but let's see it. Because I think you're the one who's talking about the EOBs. So now we have this reimbursement field team looking at the EOBs, for instance, Medicare, 1.45 a milligram. We have Cigna. Actually, we have some coming out at 2.66, $2.66 per milligram. So yes, exactly. So we're starting to now say, hey, listen, uh, don't just, it's not just the no pain act, but it's now reality. It's actual reimbursement that they're seeing, and they can look at their own revenue cycle reports. That has been resonating deeply with some of these facilities, not just in the ASCs, but in particular, and you mentioned it earlier, in the HOPD setting, because that's really where it looks like those cost offsets. So we are seeing it. We believe that message is resonating. It's early. It is early, but the implementation, those facilities that are embracing no pain, the Medicare, the separate reimbursement, and now we have those commercial ones coming in there and showing them their own revenue cycle reports. Those are the ones that are starting to adopt the Expo utilization, no doubt about it.
Jen, you want us to comment or should we leave you alone?
No, hi everyone. Good evening and great to be here. No, we've been surveying the market. We see really encouraging signs. The facilities are starting to pull this through. I think the key challenge is foot still on the gas because you cannot over message this enough. And, this is not just one stakeholder within a facility, it's 7 or 8 people who need to implement this. It's the surgeon, it's the anesthesiologist, it's the director of pharmacy, it's the biller and coder. It's just there's some multiple stakeholders that need to get messaged on this in order to operationalize that. And that's what we're focused on and trying to provide resources to all of those people because they look at this in a slightly different way. And that's why Todd's team is out there, our area managers just doing whatever we can to make sure that we're properly educating the market. So foot on the gas, nonstop, but I'm very encouraged by what we see in terms of facilities really starting to pull this through.
Excellent. There's a couple of questions in the chat area. We'll start. Kevin Evans, are you around to ask your question about Maryland? I don't know if he's here.
Yeah, I'm here.
Yeah. You asked a question about different types of reimbursement systems, about whether or not this is reimbursed in Maryland specifically, because they have a different.
Yeah, I mean, Dr. Murthy might be able to speak better to this, but I know Maryland has a different reimbursement system from what I understand for the hospital systems. And I was looking into this a little while back, and from what I could gather, I was told that the extra J code reimbursement would not apply to the hospital setting in Maryland because of the different reimbursement system, but it would apply in the ASC setting. So, but I'm not, I don't know for sure. And I was just wondering about that because Maryland's different on a lot of things on reimbursement.
I will jump in and say that, and Todd probably can back me up here, that it's a federal J code, just like your CPT code is through CMS, so is this. So it is covered. There might be other state stipulations and laws that are in place for other sort of treatments, but this is covered for the entire US. Am I correct, Todd?
That's correct. That's correct. And I don't know, Kevin, if you're going like the actual Medicaid state. I don't know where you're going, but yes, you're 100% right in terms of CMS, Medicare, that's covered.
Interesting. And Heidi Barbary had a question. Heidi, you want to unmute yourself? If not, I'll ask you a question for you.
Sorry, guys, I'm on a bike.
That's all right. Could be worse.
Multitasking at its best here. So I was asked to ask the question about where does OnQ fit in terms of can you use both Exparel and OnQ for your total knees? Is it one or the other? Just hoping to hear about somebody's TKA protocol post-op.
Right. So I guess if we could summarize the question is, does the No Pain Act allow you possibly to use multiple modalities, or do you have to choose one? I mean, it's a clear question, right?
That's a Todd question. I think the three of us that are on this call don't do total knees. So
Yeah.
Yeah. I don't know if folks use one or the other. I mean, I would ask the clinicians, do you guys use multiple modalities in that? Would you use OnQ and EXPAREL the same? Or yeah, I would ask you guys on that one.
well,
Is
I
there
think
a-
so. I think it's a little different in the knee because you're going to probably do the Exparel like capsular and everything through there, and then do like an adductor block where you're on cue pump. Whereas I guess you could do a on cue pump and you could do a field block for Exparel, but I just don't think that in the shoulder it is necessary. And I don't want to speak for Joe or Anand, but I don't think it's necessary. But and maybe in the knee it would be. I don't know. I haven't done a total knee in over 15 years.
I was on a public policy call not long ago, and from what I understand, at this time, CMS has not determined that they're going to cover one product over another. So, for example, at this time, it appears, and the proof is in the EOBs, that this policy would cover both iovera and Exparel in the same patient. I can't see a reason why you would ever need Exparel and OnQ at the same time. I think there'd be more overlap there. But would
Yeah,
it be?
Laura, my mom just got a total knee today. She had iovera covered by Medicare a few days ago, and then she had an Exparel block today. So it absolutely does cover it 100%. So I can tell you from personal experience of our EOB today that that is true. I don't know about the Q, but I think, like you just said, I think the Exparel and the Q pump are kind of considered interchangeable.
Wow. Is it compliant for us to share redacted EOBs on LinkedIn?
Yes.
Okay.
Don't listen to me. Don't listen
Okay,
to me.
we got it. We heard from the regulator.
I'm compliance. I'm the Joey compliance.
Yeah,
It may be labeled
Joe
as,
compliance
I'm
officer.
Joey's compliance
material.
department.
Anand, you'd be amazing for HR.
Love it.
And just put this was not recommended by
Everything gets through. Everything gets through.
Everything gets through. This is a Joey event, so
Can I ask a question about iovera? I don't have experience with it, but is there any utility in the shoulder? Has it been used in the shoulder, studied in the shoulder, or off-label in the shoulder? What's the
I think
current?
there's some present studies in place for suprascapular nerve with iovera, but I think they're working on a needle length that was appropriate in length.
Yeah, there are two studies, Shariff, going right now on iovera for the shoulder.
All right.
It's really fascinating. We're sort of like I always said every week, this is the quickest hour of the week. Okay. Unlike a revision hip where every minute goes slow as hell. Joey hours go pretty quick. I'd like everyone, I'm going to call on some people to sum up some a bit what they talked about today, a bit where things are going, and some comments also about what you see in your community as the status of the current opioid epidemic. Are you noticing less patients coming back for more drugs and a group like that? I'll start off with Shariff and I'll go through everyone who I recognize.
So I will say that there's definitely a big push for less opiates. And, I write for 10 Norco 7.5. So I'm like lower end of the totem pole even. And more often than not, they don't get filled with a multimodal approach using Exparel. And so now I'm getting more people that are coming in saying they don't even want anything or what's the least amount of opiates they can get. And that's something that 20 years ago when I started practice, I would have never thought I would hear. I think a lot of it comes with education and understanding from what's out there. I think it's how we talk to our patients and counsel our patients regarding opiate use and pain and understanding that, yes, you're going to have pain. You're going to be comfortably uncomfortable after surgery. And once they understand that, then I think they start understanding how they're going to feel after surgery. They're not scared about it, not worried that they need opiates. And then finally, I think it's important to talk to the PACU nurses that are going to maybe not be as familiar with Exparel and be saying, well, the second you get your fingers back, you need to start pumping the opiates. So, because you don't need to, we know that. And so I think there's that education with them so that they're not getting mixed signals from what I'm telling them, my PA's telling them, what the resident fellow is telling them, and then finally the PACU nurse telling them something completely different, or even anesthesia. So I think it's here. I think it's only going to get better, and I think our patients are going to get less opiates and still be very comfortable.
Joe Abboud, some comments?
Yeah, I mean, we definitely have improved. I think we have to be careful that we don't, as somebody said earlier, take our foot off the pedal, because, you know, we still have quite an opioid epidemic in this country with the fentanyl crisis. And, you know, I think obviously as orthopedic surgeons, we've done a better job, but society in general, we still have huge opioid addiction. And whether it's orthopedic surgeons or other avenues that people are getting these drugs, we still have to make sure that we're continuing to educate and the message is out there. And I think in the last year or so, at least in the public eye, I haven't heard as much about it on things like special series on Netflix or coverage on different media channels. So I think we need to continue to do things like this to have the exposure to society as far as the dangers of opioids. So I think, you know, people forget what the recent past has shown.
Yeah, absolutely. Todd, some comments from industry?
Yes, look, first of all, Dr. K, thank you so much for having me, and this panel has just been, fantastic. And what I want to say is, look, this no pain, it's so important because it's so incredible to see all of these stakeholders come together and really for society and the greater good. And what I would ask, for everyone, for this No Pain Act, I can tell you CMS, I mean, this is a 3-year No Pain Act, and they're going to be tracking results. And if we have the ability to define our own rules of engagement here, meaning that we need to track, did it actually do what it say it was going to do? Did it reduce opioid utilization, readmissions, length of stay, opioid use disorder? So if we continue to track those results, we're going to be doing that as a company. But if anyone wants to partner up, I am all ears, and we'll be there and we'll partner with this, because right now we're 1 quarter in, and so we have a long way to go. But early signs in terms of the receptivity with the HOPD setting, the ASC setting, the clinicians, and the payers have been very, very receptive to hearing this, to minimize barriers to non-opioid pain management like Exparel. So we are right now working with all of you together to really show the value of the No Pain Act, and we're going to continue to track these results as well. But I do want to say thank you, Dr. K, to you for hosting this, and all the folks on the line today. It was just great. Everything you guys were talking about was really resonating to me, so thank you.
Great. Anand, you want to make a comment or two, or?
Yeah, I think I concur with everything everybody said so far. It's such a huge difference than when I first started practice, how much we've come. But, wouldn't it be great if everyone was on board, and like Shariff said, it was just a routine thing to have no opioids after surgery. So I think we'll keep pushing it. We do need support, from our friends at Pacira and other companies that can help us, because we're busy, we're clinicians, and it's tough fighting against P&T and big health systems. But I think the more education we have, the better.
Great. Michael Redland.
So congratulations to everyone on this panel. And one of the big things that I've discovered, 2 things about the No Pain Act. We've been talking about it, went into process January 1st. There is a large percentage of the population right now that has no idea what it means, what it stands for, and what it implies. So we need to educate. And I talked to a colleague just last week whose father had a knee replacement down in Miami. I said, well, do you have Exparel? The hospital said it's too expensive. So there still is the message. You have to shout it out. You think we've come a long way. We're only really at the very starting line, and we've got to keep pushing education about the No Pain Act. Don't let hospitals, healthcare systems say, hey, it's too expensive, because it's too expensive? Opioid addiction. Thank you so much for having this panel.
Great. And I will ask Lara Wynn to OG from Joey to bring us home for a couple of comments.
I just think these are just incredibly exciting times. I think back to many years ago, where I was at an Access, American College of Elbow Shoulder Surgeons, where I introduced Exparel to Joe Abboud and on Murthy, Paul Sethi, very early on. I mean, opioid sparing surgery was not a popular topic back then. And I agree, with the comment that Joe made. This has become, opioid sparing surgery became, and the OR being the gateway to the opioid epidemic, got so much media attention for a while there, and it's quieting down as far as when we watch the news, but it hasn't gone away. And, we need to keep beating this drum. And the No Pain Act and the CMS rule are just incredible tailwinds for advancing opioid alternatives in this very important area. And orthopedic surgeries are the most painful of all surgeries. So a really inadvertent gateway. And it's so exciting to see the support from just this incredible group of leaders in orthopedics who are all on board and beating this drum right now.
Great. Vani, I'm going to actually, you posted an image of a movie star. You want to make a comment about the image?
Oh, yeah. I just had to show everybody she's post up day 0. And I don't know if anyone sees in the chat, but she had an Exparel Brock. She had non-opioid medications, and she had an iovera earlier. And she says right now at whatever, 9 o'clock at night, that she's had 0 pain, and she got her knee replacement at 10 a.m. this morning.
Wow.
So
Wow.
there's our testament.
About a hip chair for her there, Bonnie.
Ha ha. Start loading knee replacements, Joe.
Well, listen, I want to thank everybody. This is always a great group. As a semi-honorary shoulder surgeon, I'd like to be with this group as much as I can. And I want to thank everybody who contributed to this important meeting. Thank Pacera for lending us Todd and Jen, and also for support of the evening, but more importantly, support of this incredible act that, as I didn't even know, it has only 3 years. So, I think it's something for us to keep in mind and keep our foot on the pedal. I want to thank everybody for coming tonight. This is the first Joey session this year. We're going nonstop until the end of the year. Quite a number of different topics this year, and we're going to have some fun. So thank you so much for coming tonight.